bread and butter pediatrics right here. Common acute pediatric illnesses, benign self-limited illness. Yes, this is what I do all day long, stamping out benign self-limited illness. Lists the age-appropriate differential diagnosis for pediatric patients presenting with each of the following symptoms. So I think as we move through these, I really want you to stop and make your own differential diagnosis before you listen to mine. Okay? It's good practice. Differential diagnosis making. You should be good at it at this point. You've been doing it for 28 days. All right. Abdominal pain. Go. Okay, my turn. So, abdominal pain in an infant, I'm going to think about milk protein intolerance or intolerance to their formula. Constipation, certainly your malrovolvulus intussusception if we're getting into that severe pain, vomiting business. Those are the big things in an infant. UTI, Pilo could do it as well. In a older child, intussusception would be in a toddler. In an older child, gastroenteritis or intestinal infection, constipation is probably your most common. Functional abdominal pain or psychosocial abdominal pain, somatic pain, UTI, dysuria, pyelonephritis, renal stone. I have occasionally seen that in a school-age kid. Ovarian cyst torsion, sometimes scrotal processes like scrotal torsion or testicular torsion can cause abdominal pain in boys. Stomach ulcers, reflux, gallbladder issues. I do occasionally see those, particularly in kids with hemoglobinopathies like spherocytosis or sickle cell disease. I'm sure there's more, but that's a pretty good differential. Swollen lymph nodes in the pelvis can give you abdominal pain as well. I'm blanking on the name of it, but lymph nodes in the belly and the pelvis can cause abdominal pain, and usually that's from some sort of infection. Cough and wheeze. Typically, coughing is going to be viral URI, though foreign body, reflux, cookies and milk syndrome. You should Google it. Julie Way wrote a fantastic article on cookies and milk syndrome. My watch is fussing at me to stand up right now, but I'm going to keep talking. You should Google that. It's fascinating. TE fistula, tracheoesophageal fistula could present as cough and wheeze as well. Certainly with wheeze, you're going to be thinking more bronchospasm, asthma, and the various causes associated with that. Allergic causes versus non-allergic chemical causes like tobacco smoke. Diarrhea. Going to be infectious the vast majority of the time, although in toddlers we very commonly see toddler's diarrhea, which is from drinking juice. Too much juice is bad for you. Don't forget about your adolescent children who purge with laxatives. That's also a common cause of diarrhea. And your ulcerative colitis or Crohn's kids with the bloody diarrhea later in adolescence. Some irritable bowel syndrome kids will have alternating constipation, diarrhea. That could really go either way. Fever and rash. Let's go, we're going to talk about bacterial causes because down a few learning objectives, we're going to talk about viral exanthems, but Hemlock Shineline purpura, HSP, go ahead and review that rash that's associated with that. Strep throat rash, the scarlatina rash that you may see associated with that. Meningococcal rash, meningococcemia. Be a good time to review that one as well. Fever without a source, FUO, fever of unknown origin. It kind of reminds me of UFO, but it's FUO. Hopefully FUO becomes a fever with a source when you get a proper investigation, but you need a thorough workup to determine. I've seen kids with FUO end up having bilateral osteomyelitis of their tibia at 9 months of life. I mean, it's just rare and bizarre, but you need to go looking if you can't find a source for the fever, particularly if the fever persists or the child has a worsening clinical picture. Headache, your differential diagnosis is going to be stress, psychosocial, migraine, tension, sinusitis or acute infection, URI. hypertension, intracranial hypertension, pseudotumor cerebri, substance ingestion or withdrawal. Lethargy or irritability. Parents come in all the time and say they're so lethargic, but the kid's like bouncing off the exam table. So not feeling well makes us all lethargic. Honestly, looking at myself in this light here, I look a little bit lethargic. I am a little bit sleepy. It's almost 6 o'clock. I'm tired and I'm ready for some dinner. But I'm going to keep plugging along at these learning objectives here. So any illness can make them lethargic. Any fever, teething can make them irritable. The differential diagnosis for that is quite large. Common viral exanthems. 1, 2, 3, go. You got this. You can do it. I hope you've seen some of these. All right. Hand, foot, and mouth. Review what that looks like, particularly if you haven't seen it in the office. Roseola, and then fist disease or erythema infectiosum. Review those causative organisms as well. Describe findings associated with normal tympanic membrane, acute otitis media with effusion, using proper techniques and skills. So the normal TM is going to be gray and shiny, and you've got that gray cone of light. You can see the bones, the cone of light as well. Acute otitis media is an ear infection behind the eardrum. It's going to have yellow, like my shirt, yellow, purulent fluid, bulging, red, disgusting, just fulminant infection. You look at it and you think, man, I bet your ear really hurts. Otitis media with effusion, you may have distortion of the light reflex, but the fluid may be clear, and you can use the insufflator if you've got a good seal to see if the eardrum will wiggle when you puff air against it. A lot of times it's hard to get a good seal with a wiggly kid. Manage options for uncomplicated AOM. In kids less than 18 months to 2, we always treat AOM, acute otitis media, because fluid behind the ears limits language development, and really that birth to 2 age is the critical time for language development. So we really need to get that fluid out of the ears so they can start developing language and learning to talk, hearing and learning to talk. Above 2, if they're afebrile and the infection is only in one ear and they're really not symptomatic, you just found it incidentally, you don't have to treat. You can just use supportive care measure and tell the parent if they become symptomatic, develop fever or pain, that you can begin treatment at that time. Above school age, you can just treat with ibuprofen even if they become symptomatic, unless they have worsening of their clinical picture, at which you can go ahead and start antibiotics at that time. So not all ear infections have to be treated. In fact, most ear infections are viral, or they're a bacterial process that's going to self-resolve. It's just in those little guys that we really need to get that pus and fluid out from behind the ear that we're going to be super aggressive with the antibiotic therapy. Benign self-limited illness, check.